Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Welcome back to Season 3 of KidzDocTalk with Ask Dr. Jennie. Today's guest is Dr. John Pinson, and we talk about what we name the viral tridemic. Dr. Pinson was born and raised in Canton, Ohio. He attended the University of Akron for undergraduate school and Northeast Ohio Medical University for medical school. After completing his education, Dr. Pinson started his residency in Pensacola, Florida, with the University of Florida program at Sacred Heart Hospital. After completion of his training, he decided to trade the snow for the sun and stay in Florida to begin primary care pediatrics. Dr. Pinson has been with Pediatric Associates for 2.5 years and was recently promoted to assistant lead physician at the Hollywood office. Welcome, Dr. Pinson.
Hi, Dr. Pinson. Thank you so much for being here. Welcome.
Thank you so much for having me. I've been really looking forward to this, and this is a great topic to talk about, so I'm ready.
Yeah.
I'm ready.
Oh, good. So we were just chatting before to hit record that I'm sure it's super busy and very crazy in the office. I've been hearing from a lot of my friends and colleagues who are out working in the offices how this is a little bit of an unusual season, right, that we're in. So tell me a little bit about what's been going on. What has been unusual about the last few months in kind of like, outpatient pediatrics?
Absolutely, and I think your friends and family, everybody's hitting the nail on the head. It has been absolutely busy in these offices. I've had quite a few families come up and say that they were having trouble getting appointments and to see me just because we've been seeing so many sick kids. And this viral season has been really, really different compared to the last 2 years, especially. The last 2 years, we've been hearing nothing but COVID. But now we're starting to see a reemergence of some of these other respiratory viruses that kind of took a back seat these last 2 years. The two ones we've been hearing circulating around are RSV, or respiratory syncytial virus, and the influenza, of course, which is your yearly flu bug. What we've been noticing, though, and this is different than in the past, is that the incidence or rate of infection seems to be spiking a lot earlier than it has in previous years. Normally, I would say most offices would hit their stride as far as number of respiratory virus patients coming into the office around January, maybe early February, but we've been seeing it a lot sooner. November was busy. December has been busier. And this is very different because now we're worried, is this going to get worse? Is this as worse as it's going to be? And especially for some of our more acute care settings, like in the emergency room, urgent cares, they're worried about the burden that could possibly happen. Like, are we going to be overrun like we were with COVID and not be able to give the kids that are coming in the care that they need? And that's where we're kind of running into the situation where people are starting to call this the triple-demic of sorts, because they're worried it's going to be another COVID, but with more viruses.
So one of the theories that I've heard about why we're seeing some of these viruses emerge sooner or earlier than we typically would is because, right, we had COVID and we had kind of kids indoors and masked, right, and out necessarily outside of their like typical sort of crowded environments like childcare. And now that we've sort of eased all restrictions, now we're seeing an uptick in those viruses. Does that kind of make sense to you? Or are there any other reasons that you think that we might be seeing stuff sort of outside of the typical seasons?
Yeah, I think that makes a lot of sense because really the things that we should be doing anyways to prevent a lot of these viruses were the things that we were doing for COVID. So it wasn't surprising when we started masking up and having some of these policies in place that not only did we see a loss of COVID cases kind of drop, especially in pediatric patients, but we also saw not a lot of flu, not a lot of RSV, and not a lot of those other viruses. The other thing too is some people feel that because we were isolated and because we weren't in school and we weren't getting together with a lot of kids, there wasn't a lot of opportunity for some of these viruses to spread, and we also weren't able to develop a lot of immunity prior to. So there's billions and billions and billions of viruses and even more subtypes of these viruses. But every time you get a virus, you kind of get a little bit of immunity so that maybe the next year, if you got a similar virus, you might not get as much an illness with it because you already have at least some immunity developed towards it. Whereas some people are feeling like since we were a little bit more isolated, maybe we didn't, maybe we are getting some of these viruses a little bit stronger because we didn't get that immunity as much.
So that makes sense. So billions of viruses, right? You guys are seeing a ton. You mentioned, two specific ones. So I want to pause a little bit and talk a little more about those. So RSV, everyone that hears about RSV, I think gets very concerned, and certainly RSV can make some patient populations very sick. But I want to talk more about kind of like the more typical or the common things that we see with RSV. So what is it, and when should we worry about it?
Yeah. So first of all, RSV stands for respiratory syncytial virus, and it's actually not new. Although a lot of people are touting that it's the new COVID, but it was actually discovered in the 1950s, and pediatricians have been dealing with this for years. It's a single RNA virus that loves to infect the respiratory tract from nose to the lungs. And it is a common cold virus, typically, and it peaks around this time, the winter season. It has a variety of presentations like COVID does, and it presents very similar to COVID. In general, most people are going to be either asymptomatic or they might have your typical cough, congestion, runny nose, maybe decreased appetite, plus or minus flu. But with RSV, you can also have some more severe presentations like pneumonia, or for our younger kids, we worry about bronchiolitis. Bronchiolitis means inflammation. Whenever you have itis, it means inflammation of, and the bronchioles refer to the small little airways inside the lungs. So small airway inflammation disease. We worry about this particularly in our younger kids, kids under the age of 2, particularly under 6 months. Other babies that are kind of more at risk would be your premature babies, especially your ones that are under 30 weeks gestational age, those with chronic lung diseases, including asthma, and your babies that have chronic heart defects, or your babies that have issues with clearing their airways. So these would be your kids with neuromuscular disorders like cerebral palsy, for example. In the grand scheme of things, this is a virus, and like other respiratory viruses, it can last 7 to 10 days. You present a lot of times with runny nose, cough, congestion, maybe fever. For the babies, they're going to be fussy. They might have some vomiting, especially after they have a coughing spell or after they're trying to feed. Most of the time, the viral symptoms tend to worsen around day 4 through day 6. And this is the time when a lot of kids will end up in the healthcare system because they're reaching the peak of their symptoms. As a healthcare provider, the symptoms that make me most concerned are the signs of increased work of breathing. That would be nostril flaring, so they're breathing so hard that their nose is getting bigger. They're head bobbing, they're moving their chest, they're tightening their neck muscles. Other things that you can see would be rapid and shallow breathing, looking tired out. Like if your baby looks like they ran a marathon and they're breathing very heavily, that's concerning. And poor drinking and decreased pee-pee diapers.
Yeah.
That's what tends to get these kids in trouble, when they're breathing so hard that they can't really drink and keep up with their fluids. That means they're using up a lot of energy, they're not going to be having a lot of oxygen going to those tissues to do the work that it needs to do, and they get tuckered out. And that's where they end up in the hospital.
So I want to sort of reiterate something that you pointed out, that the overwhelming majority of kids who get RSV really do quite well with it, right? It's a virus and they don't feel so good, but not necessarily something that we want them going to the emergency room. However, I think you kind of summarized the red flags very, very well in those special patient populations that we want to keep a close eye on. I generally feel like there's so much goopiness. This is what I like to tell parents. There's so much goopiness with RSV. There's so many secretions, right? That the smaller babies who have teeny tiny airways, or our babies who were born prematurely and have teeny tiny airways, or babies that you mentioned that are, right, have neuromuscular diseases like cerebral palsy that can't cough so well and they have teeny tiny airways, right? That's like, it's a lot. It doesn't take a lot of goop or a lot of secretions to overwhelm those airways. And so they end up with the cough and the runny nose and the vomiting, the phlegm and all of that. And that really is what can be very overwhelming for them.
Yeah. And I remember when I was in residency, one of my senior residents actually explained this to me very nicely, and I kept it in my head. for the babies, it's almost like when we're working out, well, I should be working out at the gym, and when you work out too hard and you start going into, getting muscle fatigue and whatnot, for your babies, they have to work really, really hard to keep those airways clean. They have to use up a lot of energy. And when they are tuckering out, just like how you would build up lactic acid in your muscles from from working out too hard, babies can also build up lactic acid, but from breathing too hard. And if you're not able to address that properly and get rid of that lactic acid, it keeps building and building and building, and that's what gets the kids really, really sick. So the primary treatment, kind of going into what you were saying, is clearing out that airway, especially before a feed. As long as your baby's feeding okay and drinking okay, then your baby will get through it. They might be upset, they might be cranky, they might be very goopy.
Yeah.
But they will make it through. It's the babies that are struggling to keep up their liquids that I'm most concerned about.
Agreed. Yeah, I think suction is your friend. I mean, RSV especially, all viruses, right? We know suction is your friend, saline infection for sure, RSV especially. So, we do have, I'll call it a little bit of a tool, right? Not a great tool, and not a universal tool, but a little bit of a tool to prevent RSV. Let's talk about that.
Yes. So first of all, as far as treatment, yes, the mainstay treatment is suctioning out the nose. But the other thing is prevention of spread. And that would be making sure you're washing your hands, making sure you're Lysoling and cleaning everything, making sure that if you are sick, you stay away from other people that are not sick. You keep your kid home from school, keep your kid from daycare, keep other family members isolated away from the house. There aren't any medications or vitamins necessarily that prevent contracting RSV, but in general, a healthy diet, a good amount of sleep, and decreased stress can help to decrease your risk for any infection. But specifically for RSV, there is a vaccine that is available. However, it's not recommended for the general populace as of yet. The vaccine is, oh goodness, I'm going to mess this up, pavlizumab.
As we like to call it.
Synagis.
Right.
Synagis, pavlizumab. There we go. All right. So what was it? Well, let me try that again. All right. There is a vaccine that's available for children that are at risk. It's not available for the general populace. It's called pavlizumab, or what we call Synagis. And it's available for specific populations of patients. So again, your premature infants under 29 weeks gestational age who are under a year of age, your babies with chronic lung disease, your babies with heart disease, your neuromuscular disorder kids. It's typically offered from July to November, if I remember correctly. It's 5 doses spaced 1 month apart. I believe, I was looking on the CDC website prior to getting ready for today. I believe that they are trying to find another vaccine, or they are trying to get some other treatments available. There was a medication at one point, ribavirin, but its use is controversial at this time.
Okay, so certainly not something that we can offer for all patients, but those higher risk, right? Those premature babies sometimes can benefit, and I think it works as a monoclonal antibody. I don't think it's necessarily a vaccine. We kind of just call it that because it prevents severe symptoms with RSV. I think there is some talk of expanding it beyond those specific patient populations, but as of now, I think not quite available to everybody. So I want to switch gears. I think RSV we kind of covered well. I want to talk about something that actually scares me a little bit more than RSV, which is flu. Flu makes me more nervous than RSV, and I think this year especially, flu is very severe. So let's talk about that. What's unique about flu compared to other viruses?
So influenza is a very sneaky and very smart virus. It's also a single-stranded RNA virus, but in a different family from RSV. But the thing about it is that it comes in a variety of flavors. There's a whole ice cream shop of flu viruses, but there's 2 overarching categories, if you will. There's influenza A and influenza B. The majority of your flus are going to be influenza A that we see in the office. And this is where you get your H1N1 flu variants. Yeah. The H and N are actually acronyms that stand for 2 proteins that live on that outer shell, that outer envelope that encapsulates that virus and allows it to move from host to host. the flu exhibits two specific evolutionary features that make it stand the test of time as far as causing horrible illnesses, but also surviving year after year after year, despite us having a vaccine that we update every year. And this is called antigenic drift and antigenic shift. Antigenic shift, thankfully, is not as common as antigenic drift, and both of them involve changes in the structure of the flu itself, especially those proteins that I mentioned before. As the flu virus mutates and evolves, you can have little genetic mutations that change how those proteins on the outer shell look. And it can trick our body into thinking that, oh, this is a new virus. I don't recognize this, even though it's just the same old flu. And this is why we have to create a new flu vaccine every year. We have to look at lab samples from other patients accumulating over the year. And with our best estimation, we're not perfect, but our best estimation, we create a vaccine that covers the likely strains that will cause the biggest burdens on our society, meaning those that will cause the most severe illnesses. And then antigenic shift happens more suddenly. This is a situation where you say you have a situation where two flu viruses meet together in a single host. They can do some swapping of genetic material and create a novel virus. And this is where you get some of like your major flu pandemics. And thankfully this doesn't happen often, but this is very difficult to predict. And that's what makes it so scary. But the thing with the flu is that, again, you can have a variety of presentations, and some of them can be very mild, but also that can be very, very big, and you can have flu pneumonias. And as a matter of fact, flu pneumonia can also open you up for bacterial pneumonia as well. Patients with flu pneumonia are higher risk for getting staph, which is scary.
So, I think I feel validated of sort of, having a very healthy respect for flu and sort of taking it very seriously and not just treating it like another virus, right? I think, as you pointed out, those kids can get much more sick. So you mentioned one of my favorite things, which is the flu vaccine. So I want to talk about that because sometimes I find that parents don't necessarily want it. They don't feel like, right, it's not mandatory, so maybe we can skip this one. What are your thoughts on it, and how good is the flu vaccine? How good of a job does it do, especially maybe this season, at preventing complications from flu?
I have been especially pushing the flu vaccine this year because this June, which is typically not flu season, was crazy. I had so many kids that came in, I thought they had COVID or I thought they had something else, but they had the flu. So I think that getting the flu vaccine this year is definitely important, especially given the fact that we already have other viruses that are starting to pick back up, and because of the possible burdens this could have on the healthcare system, my thought process is, if there is any marginal protection that you can get, why not? Absolutely. So the flu vaccine is offered for kids 6 months and older, and we recommend it at least yearly. Bear in mind that if it is your first vaccine between 6 months and 8 years of life, you actually need 2 doses spaced 1 month apart. So don't forget, if you have a younger baby, to come in the next month to get the other dose. So that way your baby can be completely protected and armored up for this season.
For sure. I think another important point, because sometimes I get pushback like, oh, well, we've gotten flu before, it's not so bad, or we never get flu, right? So an important thing is, just because you've never gotten it doesn't mean you can't get it. And certainly with the season that you're describing, sounds like the risk is high. And the illness or the degree of illness also doesn't necessarily correlate to what happened in the past, right? So you may have had a mild case, but you just discussed a lot of the ways that flu can be sneaky and smart and sort of evolve and can cause really, really significant illness that, right, children can end up in the hospital, not just necessarily with breathing things or pneumonia or even bacterial pneumonia like you described. We see a lot of flu myositis, right, which is muscular inflammation, and kids aren't able to walk, right, it takes a few days in the hospital with some IV fluids. So certainly things that we want to avoid, and I think if nothing else, the vaccine generally does a good job of preventing kids who have to end up in the hospital.
Yeah, and bringing up a point that you mentioned, like when people said that they didn't get sick with it as bad last year. one thing again, that doesn't mean that that's going to be the same case this year. There are other variants, and just like there's other variants of COVID, to kind of nail that point home, you can get a more severe presentation, and our goal is to help prevent the severe illness. So yes, there are some situations where you can get the flu shot and you might still get the flu, but it's going to be a significantly weakened version of it, likely, and the likelihood of you having complications is going to be much, much, much lower.
Yeah, 100%. And I think we see that with the population that's hospitalized, right? Overwhelming majority are kids who are unvaccinated. But it's probably true in adults also, but I can't speak to that 100%. Definitively. But I know for sure in the pediatric hospitals world, it's overwhelming majority are kids who are unvaccinated end up in the hospital. So you mentioned COVID, and I think collectively we all kind of do like, again, but it's still here. So let's talk about what you're seeing right now with COVID. What is the most recent variant like for kids?
So yes, we are still seeing COVID. I just had patients with it last week. Granted, we're not, thankfully, we're not seeing as severe of illness that maybe we were seeing with some of the older variants like the alpha and beta variant. As far as we're not seeing as much like MISC, it's still there, but maybe not as much. But with this current variant, yes, you do kind of get respiratory viral symptoms similar to the flu and similar to COVID. We are seeing it affecting a lot more younger kids, especially your kids 6 months and younger. Overall, my understanding is that the rates of hospitalization have decreased overall, but we've seen an uptick in the amount of hospitalizations in the younger kids, because I think this virus is starting to affect the younger kids now. While I was looking this up online for my preparation, while the rates have decreased from August to now, their expectation is for the hospitalization rates to peak back up, especially as we enter deeper into viral season. So it's still something that warrants our attention. It's still something that warrants our respect. And we should still be cautious of it as healthcare providers and as parents to our kids.
Okay, good insight. So we've talked a lot about viruses, and you did a good job summarizing the treatment for it, which for the most part is time, right? And what we call supportive care, saline suction, making sure the child stays hydrated. So a little bit of a separate thing that I want to ask about is the antibiotic shortages. So just so that there's no confusion, we're not suggesting that antibiotics are the treatment for viruses. We know that antibiotics are not needed for viruses, but nonetheless, I think something else to add, like, as if you needed more stress to the viral season now, you're also dealing with some antibiotic shortages. So what is going on, and how is it affecting our patient population?
Yes. So a little bit more from what I've been understanding is, and correct me if I'm wrong, I know the American Academy of Pediatrics, or the AAP, recently just issued out a statement in November, early December, talking about that there were expected shortages, particularly for the amoxicillin suspension or the liquid formulation. So amoxicillin, we use that for a lot of things. We use that for ear infections, for sinus infections, even community-acquired pneumonia, we use that. And especially given the fact that we are starting to see more respiratory illnesses, that kind of gives us a little bit of worry. Having said that, though, one thing that's important to clarify, we do have the antibiotic. It's just not in the liquid form. So that's just not to cause alarm for people. It's just, we're just going to have to kind of modify our management a little bit.
We're getting creative. We're going to get creative, right?
Exactly. Be creative. Yeah. So there are pill formulations, there are capsule formulations, and those can be crushed or emptied, and you can mix it in applesauce or chocolate sauce, something like that, and you can administer it that way. Heck, it might be more tastier for the kids. They might enjoy it more. Having said that, though, this does bring up a very, very important point for us prescribers. Historically, we do tend to overprescribe a lot of antibiotics, and there's actually a lot of research going into this, and we do need to be a little bit more judicious with our antibiotic prescriptions. As a matter of fact, here at Pediatric Associates, thanks to Dr. Fabiana Izquierdo and some of our other providers here, we have actually been enrolled in the BIOS program, which is a quality improvement project that looks at how we're prescribing antibiotics, offers us feedback and provides us with more education. The goal of this is to really, really help narrow down our illness pathways and really help us draw that line as far as when do we start antibiotics, when do we think this is bacterial versus viral. At the end of the day, a lot of kids might have ear infections, but the majority of these are still caused by viruses. But it's very, very hard sometimes as a provider to tell a parent, your kid has an ear infection, but I'm not going to give you antibiotics. And there's a lot of research going into that as well. But the goal of this is to help us determine, we're going to give you antibiotics because you have this and this and this criteria, versus we're not going to give you antibiotics until this and this criteria are met. And how do we approach that?
I love that. I live and die by antimicrobial stewardship, so I love everything about what you just said, but I agree. I think that the recent shortage doesn't necessarily mean that we change any of what we do, but I think it's a really, really good hard stop for us to be like, hold on. I'm going to have to get really creative if I really want to treat this child. How strongly do I feel that this is bacterial? Because you're right. Sometimes it takes maybe a little bit more of a conversation with the family, a little bit of shared decision making, which I also love implementing, but sort of having an understanding with the family that, hey, like maybe we will need antibiotics. Right now, the way things look, we don't. But let's walk this, right? So let's reevaluate in 24 hours. Let's reevaluate in 48 hours. We know a lot of those ear infections will clear up, right? We know a lot of pneumonias are viral. And so, right, we know those sinus infections are probably just like, right, congestion that's not going away, not necessarily something that needs antibiotics. So I agree that it's forcing us to be more judicious, which maybe is not such a bad thing.
Yeah. And one thing that's very interesting that I actually learned from the program is that a lot of times when we prescribe antibiotics, a lot of it's because sometimes our expectation is that we feel, well, not, I'm really going to change that. A lot of times when we prescribe antibiotics, it's because we perceive that the parents want us to prescribe it. Yeah. But oftentimes when you look at some of the research, it's actually not the case. At the end of the day, a lot of times parents don't want us to prescribe antibiotics if we can help it. So sometimes just having that, a little bit of extra stress taken off on us a little bit, realizing, hey, you know, at the end of the day, you know, we could, as long as we have a clear conversation with someone, we give them red flags, we give them follow-up, we talk about
contingency plan. That's all they want, right? They need a contingency plan. Like they're fine with no antibiotics now, but also as a parent, you want to feel like reassured that you're not just being blown off, and the answer isn't just like, sorry, no, it's just a virus. But I'm always hesitant to use the word just, because as we just talked about, right, viruses can be very, very scary and can make somebody very sick. So I think having that conversation, having the parent feel empowered about, okay, I understand what the plan is now. I agree with the plan. I know why the plan is what the plan is. And I also know that things will change because children change, right? And clinical things sort of evolve.
Yes. One thing I also do, especially for the kids in daycare, a lot of families get very concerned when their kids are sick for seemingly weeks on end.
All the time, right? That's
all the time.
Yeah.
Yes.
Yep.
One thing that I try to do is I try to really tease that out. Say like, okay, have they been consistently sick? Like, or is it kind of like, you know, up and down symptoms? Like they seem to get a little bit better and then they get worse. They seem to get better and get worse. Yeah. Because especially when you're in daycare and you're surrounded by other kids with snotty noses and cough and congestion, they're going to pick something else up. It's not uncommon for kids to have back-to-back viruses, sometimes up to 8 or 9 within a calendar year. And that's really crazy to think about. But I have had kids that were sick back-to-back.
Daycareitis, right?
And parents are like, if you say it's a virus one more time, I'm like, it's a virus, I'm sorry. But it's just to let you know, even that doesn't warrant antibiotics, because at the end of the day, a virus is a virus is a virus. It just needs time. So does it sometimes put kids at risk for picking up other things in addition to the virus? Of course. But it still is a virus and still doesn't warrant antibiotic treatment.
For sure. I think daycareitis is probably like a whole nother topic, because that's what I call like, right, the repeated symptoms. I say, don't worry, it's still just daycareitis. But I think it can definitely be extremely stressful. I think it's very reassuring to hear that it's normal, right? It doesn't mean that it's not stressful. it's normal in the sense that your child's immune system just hasn't been exposed to a lot of stuff before, and now it's getting hit with all the things. So the good news is that right after the first 12 to 18 months of childcare, these kids have amazing immune systems, and that this kind of like frequent illness thing sort of trails off. But certainly in the first sort of window of time when they're in childcare, it can be extremely stressful.
Yes, absolutely.
Okay, well, we covered a lot of ground, a lot of fantastic information. Anything to add? Anything that you really want to make sure parents take away from this?
Yes. So the first thing I would say is I'm all about knowledge is power, and I really want my families to feel assured themselves, because at the end of the day, no one knows your baby like you do, and we are certainly here to help you, but you trust your gut, trust your instincts, and I've always learned to listen to my mamas, because mamas are always right. So to provide some more insight and more education for you guys, some good resources. Of course, cdc.gov has the latest and greatest on all of these viruses. They have revamped their RSV section as well, especially given what's been in the news recently. The American Academy of Pediatrics has some good information. A website that I really love, I live on this website, is healthychildren.org. It's a great resource for parents, not just for viruses, but for anything, for well care, from infants to teenagers. So that's a really good place to look at. But also know that we're available for questions and concerns. I always tell my families that, once I see you once, you're always my baby. You can always come see me. You can send me messages on the portal system if you're a patient with us. You can give us a call. We want to be available for you. But the big thing is suction. Yeah. Lots of nasal saline, lots of suction, the nose Frida, the bulb suction, the electronic suckers, all those things work great. Just make sure you have them handy.
For sure. Fantastic. Thank you so much. Great information, and thanks so much for your time.
Thank you.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.